2022. My name is Manisha Kulkarni. I'm the Assistant Dean of Global Health in the Faculty of Medicine at the University of Ottawa and an Associate Professor in our School of Epidemiology and Public Health. Before we start, we'd like to pay respect to the Algonquin people who are the traditional guardians of our land, and we acknowledge their long-standing relationship with this territory, which remains unceded. We also pay respect to all Indigenous people in the region from all nations across Canada who call Ottawa home, and acknowledge the traditional knowledge keepers, both young and old. And we honor their courageous leaders, past, present, and future. Our Global Health Learning Network is a platform for knowledge growth and exchange with the goal to build a community of practice in global health that reaches researchers, practitioners, and learners from all global health domains. And as part of this Global Health Learning Network, this webinar series is a collaboration between the School of Epidemiology and Public Health, the Briere Research Institute, the WHO Collaborating Center for Knowledge Translation and Health Technology Assessment and Health Equity, and the International and Global Health Office in the Faculty of Medicine. We're really pleased today to have our guest speaker, Professor Mzikazi Nduna, who is the Dean of the Faculty of Health Sciences and a professor in public health at the University of Fort Hare in South Africa. She's an esteemed South African academic with expansive expertise and experience as an educator, trainer, researcher, and advocate for sexual and reproductive justice. Professor Nduna's research output contributes to interventions and policy advocacy and includes numerous peer-reviewed journal articles, books, and other publications. Professor Nduna also has links to Canada, having visited for a year during her PhD studies as a Carnegie Foundation Fellow to work with Professor Ian Coleman, who's now a member of our School of Epidemiology and Public Health. So with a warm welcome to you, Professor Nduna.
Thank you.
Are you able to share your slides?
Yes, I can. Should I go ahead now?
Yes, please go ahead.
All right. Can you see my slides?
We can see them, yes. You can see them in the outline view. Perfect. And so after your presentation, we'll just have some time for question and answers. If folks have questions during the talk, if you can please put them into the chat and we'll get to them after the talk. Over to you, Mzi. Thank you.
Thank you very much. Thank you very much, colleagues, for the invitation to come and join this community of practice in global health. And thank you to the students and everyone who is joining us online this evening in East London, and I guess it's morning or noon your side. So I've suggested that today we have a conversation about mental health and HIV. This is an area of work that I've been working in for a long time, since my PhD in 2009 to 2010. Worked on the relationship between mental health and HIV risk, and I specifically looked at depressive symptoms and how those influence HIV risk. And since then, and even before then, we've continued to experience problems with HIV in sub-Saharan Africa and in South Africa. We know that even today, we still struggle in South Africa and in sub-Saharan Africa with HIV, or with fight against HIV. So today we're going to talk about what we know from research around mental health in terms of this. What we know about HIV is that more than 90% of adolescents who live with HIV reside in sub-Saharan Africa. And by live, in this instance, we talk about people who actually have been diagnosed with HIV. South Africa is just a small country in sub-Saharan Africa, and sub-Saharan Africa constitutes about 53 countries, and South Africa is at the bottom of the continent. And there's quite a lot that is happening in this country. And one of the things that we know is happening is that South Africa has the highest HIV burden in the entire continent. And yet we also have the largest, antiretroviral therapy in the entire continent. So we should be getting something right, but we don't seem to be getting everything right. Why do I say that? It is because research suggests that we are still failing to reach the 95 target for adolescents living with HIV. If you are familiar with this field, we have committed that 95% of people will know their status, and that 95% of those who know their status and have tested positive will be on antiretroviral treatment, and that 95% of those who are on antiretroviral treatment would be suppressed, so that when they are virally suppressed, the virus is undetectable and as such untransmittable. So those are the targets that we have committed to as a country and as a region, the sub-Saharan region. And we know that when we talk about HIV/AIDS, it is mostly sexually transmitted in this context, and young people are at an increased risk of sexual transmission of HIV, and that is why the focus seems to be on young people. There is an 18 months to 36 months follow-up study that has been conducted in 53 facilities in South Africa in the Eastern Cape Province. The Eastern Cape Province is where I am presenting from right now. And this study shows that only 51% of adolescents reported that they have consistently used antiretrovirals. And so this suggests that we do have a problem with adherence. And this reporting was observed at both 18 months and at 36 months follow-up. So what that means is we actually reaching only about half of adolescents with the 95% target of adherence. And what that means is when we have the other half of adolescents without a suppressed viral load, it means that they continue to be infectious. And so they drive the HIV prevalence in this area. In a study that was concluded from female sex workers. So in South Africa, we have what we call a generalized epidemic. And by that, we mean that the epidemic of HIV in South Africa is not concentrated in particular groups. It is in the general population and mostly heterosexual men and women. However, even though that is what we say when we talk about HIV prevalence in this country, we know that there are particular groups that seem to have increased exposure and risk for HIV. Female sex workers is one of those groups. And in a study that's randomly selected 12 districts, it was observed that about 57.2% of the participants who self-reported reported that they were aware that they had HIV. The same study also used biological markers and tested the female sex workers, and they found the HIV prevalence to be 62%. Remember the targets that I spoke to about in the previous slide, where we are aiming to have 95% of the population tested and knowing their status. What this suggests is that there are people who still do not know their status, and that is something that we need to look at. We also look at incidence. Our prevalence rate is sitting, at around 30% in the antenatal, clinic samples. We looked at incidence rate in the female sex workers population, and we found that using a variety of sensitivity analysis, the estimates that were produced were about 11 cases in 100 person years. And this suggests that female sex workers have an extraordinarily high incident of approximately 5 cases per 100 person years in South Africa. Coupled with the problems that we see in terms of our failure to address HIV prevention, there's also the challenge of mental health in sub-Saharan Africa broadly. The mental health of young people, remember, we're focusing on young people mostly and the at-risk groups because they are the ones who are at higher risk of HIV infection. The mental health of young people in sub-Saharan Africa is set against the background of poverty, food insecurity, unsafe environments, familial stress, service gaps, and an HIV epidemic that is intertwined with the COVID-19 pandemic. We all know what happened in the 2 years, 2020 and 2021, where we had lockdowns, hard lockdowns that were eased over time. But during this time, what we saw was a lot of disruption in people's lives, especially in the global south, and especially even in places like South Africa, in provinces and in communities communities where unemployment was high, where precarious employment was high, where underemployment was high. A lot of people actually were losing their jobs. They lost income, and mental health was reported to have increased, and there was also increased violence in these communities. And we know that symptoms that are consistent with probably post-traumatic stress disorder were common among young people in South Africa. We also report the same in Uganda and in Zimbabwe. So in my presentation, you will notice that I start with the sub-Saharan Africa, then I zoom into what is happening in South Africa. A cross-sectional study of students from 17 universities in South Africa reports that about 16.3% of the respondents met the diagnostic criteria for a mood disorder in 30 days before the assessment. And also 10% experienced a generalized anxiety disorder, whilst 21% reported clinically significant symptoms of post-traumatic stress disorder. In another study that also looked at young people, a sample of about 422 adolescents from 2 communities, from 2 provinces, found that 42% of the respondents had probable depression. So the mental health of young people in South Africa continues to be a cause for concern, with multi-level modeling based on about 7,000 adult women in South Africa suggesting that violence is a strong predictor of depressive symptoms. I've spoken earlier about the disruption that resulted from COVID-19, and that is coupled by the pre-existing conditions pre-COVID-19, such as food insecurity, unsafe environments, including child sexual abuse, and these are all reported to predict mental health and sexual behaviors in South Africa. Unsafe environments, which include child abuse, continue to be persistent and are a spotlight or focus in terms of the gender-based violence interventions that have recently been highlighted in South Africa. In a study to assess the associations between post-traumatic stress disorder symptoms with sexual behavior, HIV risk perceptions, and attitudes towards pre-exposure prophylaxis among young people in Southern Africa, this study suggested a strong evidence that the higher the post-traumatic stress disorder score, that was associated with forced sex, and this is as a victim of forced sex. And here we could think about it in 2 ways, that compromised mental health state might actually make one vulnerable to forced sex, but also experiences of forced sex, which could include rape or other forms of sexual violence, a risk factor for mental health. So the mental health sequelae that results from these experiences is also observable. There was also a strong association with self-perceptions as a person who takes risks, and also increased the frequency of thinking about risk of HIV acquisition. And this makes sense because when there is a relationship between mental health and forced sex, and because in context of forced sex, there is no use of protection and barrier methods towards protection for HIV, then that might result in overthinking the exposure to HIV in those contexts. In South Africa, we have for a very long time, over 30 years, presented barrier methods such as male condoms as the main method for HIV prevention. The barrier methods, we know that they have been easily accessible, they have been affordable, and they could be widely distributed. But recently, studies have shown that there are biomedical interventions that are also affordable and could be easily accessible. And so South Africa started to roll out the pre-exposure prophylaxis, and especially to high-risk populations such as young people, men who have sex with men, prison populations, female sex workers. Even though in South Africa right now, pre-exposure prophylaxis is available to anyone on demand, but we have an added emphasis on the high-risk groups. So I want to tell you in the region, in sub-Saharan Africa, what is happening. What is happening in relation to mental health is that probably post-traumatic stress symptoms did not impact or did not influence pre-exposure attitudes or preferences among young people in studies conducted in South Africa, in Uganda, and in Zimbabwe. Interestingly, post-traumatic stress disorder did not predict or was not associated with willingness to take PrEP, so people could take PrEP regardless of their mental health. It did not. It was not associated with preference for on-demand versus daily PrEP. So on-demand PrEP is when a person has been exposed to risk and they go and ask for PrEP. Daily PrEP is the routine use of PrEP for prevention, more like you use your contraceptives. So again, people were found to have used this regardless of their mental health state and with actual HIV risk behavior, such as condomless sex. But there is another study that was done in Kenya, and this study shed some light in terms of what are the factors that are actually associated with increased use of pre-exposure prophylaxis. And this study shows that having had a recent sexually transmitted infection was associated with increased use of PrEP, having an HIV positive primary partner, and also having regular transactional sex in the past 12 months were associated with increased use of PrEP. And this regular transactional sex also included being a female sex worker. We also have observations of mental health, especially for people living with HIV and who are on antiretroviral treatment. And this is of interest because of the 95-95-95 targets that I mentioned earlier, that 95% of people who have tested and know their status should be on treatment. But for us to win the fight against new infections, the 95% of people who are on treatment should be virally suppressed. And so we also trace those, and we find research suggests that mental health provision is scarce in South Africa. The infrastructure is suboptimal. Also, we don't have skilled providers. They are missing, and there's also lack of leadership in mental health interventions. And yet mental health burden for adolescents living with HIV is very high, and it has been found in some studies in South Africa to contribute to low quality of life and to challenges with adherence to antiretroviral therapy. So this suggests that if we want to meet our 95-95-95 strategies, which we are failing to meet right now, we need to focus on the relationship between mental health and HIV. For one, for prevention, because it does affect prevention. Two, for treatment and management, but also for making sure that we reduce infectious patients or people living with HIV, so as to reduce the rate of infection. So what do we know works in this context? A lot of work has been done in terms of HIV. I've also shared the information around the biomedical interventions. And in addition to the biomedical interventions and interventions around barrier methods such as condoms, a lot of work in this context rests on what we call community-based mobilizing strategies or community conversations. And some of you may be familiar with this. The UN has endorsed the community capacity enhancement strategies as an effective intervention. And these come in different forms, and they have been evaluated and were found to be successful in different contexts. I myself have worked on one of these community capacity enhancement strategies, and these are strategies that are aimed at bringing the whole of community together in interventions to fight against HIV. One that I was involved with is the Stepping Stones program, which is also endorsed by the UN. There's quite a number of these, and there's also links between these behavioral interventions with social grants or with economic empowerment, so that there is a relationship between behavioral changes and uplifting the economic situation for people. These may include workshops which are run face-to-face or which have moved to online platforms recently. So there's quite a number of these interventions that are online now. They also, most importantly, involve leadership and stakeholder engagement. In this context, this is very important because communities still have a lot of trust on leadership, whether this is traditional leadership or whether this is elected leadership. But if these people are involved, it is easy for interventionists to access the communities, and also it is easy for the communities to inform the interventions that we bring into the communities. So that collaboration between the communities and the interventionists is possible if we engage leadership and stakeholders. Also, it involves a training of a cadre of community volunteers. And this is important, especially in relation to mental health, because mental health has been seen as belonging in the realm of healthcare services. So some healthcare services, such as distribution of condoms, distribution of contraceptives, has been delivered in a way that collaborates a lot with communities. We have in our communities people who were trained by the Department of Health as community healthcare workers. However, what we have noticed is that the training that has been given lacks a component on mental health. So our community healthcare workers, who are not clinicians by training, have not been trained on mental health. And this is what we probably need to do, to train a cadre of community volunteers as part of these community mobilizing strategies. So these strategies are called by different names. Some people call them community dialogues because these are a dialogue between the healthcare providers and the communities. Some people call them community indaba, some call them community engagement, but all of that centers around an approach to interventions that is a collaboration between the health care workers and the community. So these are known to be working because in a recent study, which was a cluster randomized control trial of community mobilization interventions to improve engagement in HIV testing, linkages to care, and retention in care in South Africa, it was reported that HIV testing increased, that also quarterly linkages increased significantly, in particular for women in the intervention communities. And quarterly linkages fell, unfortunately, among men in both arms. However, the decrease was significant among men in the control communities, which means that the intervention actually worked. Quarterly retention fell, among women in both arms, but the retention fell significantly among men in both arms. So what we need in terms of research, which I hope that the global health partners in this community of practice that the university is fostering will be able to find ways to collaborate with us on these studies. We need mental health studies in South Africa because we do not have enough data. You've seen I've quoted a few studies, but these studies are very few and far in between. We do not have a lot of research on mental health in South Africa. You may also have seen that these studies are actually based on small samples. So we lack nationally representative data sets that incorporate modules on mental health so that we are able to trace this over time. So we need those large samples. We also find that most of the mental health work tend to be based on clinical samples. And yet there is quite a lot of challenge that is in the communities, and we're not reaching that as researchers because of the focus on clinical samples. So we do need more research, but we also need larger data sets, and we need to continue with clinical samples, but also look at the general population. We also need interventions that are aimed at increasing HIV testing so that we can reach our 95 target, linkages to care so that we can reach our 95 target for ART use, and retention as well, so that people who are on ARV are actually virally suppressed and HIV is undetectable. So this remains a challenge, even though HIV treatment is universally available at no cost in all the public used public universities, in all the public facilities in South Africa. So I think that is what I wanted to share for today, so that we all think about what we need to do moving forward. So in addition to behavioral change programs for safer sex, there is a need to address food insecurity as well moving forward. And there there are other studies that suggest that there are interventions that could be put in place to increase food security, especially for the low-income communities. We also need to address safer environments, especially in terms of reduction of violence. With the National Strategic Plan that was introduced and launched in 2020, we are hoping that the National Strategic Plan will steer us in the right direction in terms of addressing violence. The strategic plan was reviewed recently, about 2 months ago, and the president is leading in the implementation of the National Strategic Plan. So we hope that with high-level political commitment, we will be able to fight violence and thereby reducing the burden of depressive symptoms. Related to that as well is substance use, because a lot of mental health, again, in a bidirectional way, mental health could result in substance use, especially with self-medication that is uncontrolled. And also substance use could also result in mental health problems. And we do have an increasing problem with substance use in South Africa. Thank you. I've given you some list of references, which are all recent references from 2022. I hope Banchis is also 2022, so that you can be able to refer to some of the most up-to-date research findings from both South Africa and Sub-Saharan Africa. You will wonder why I don't separate Sub-Saharan Africa from South Africa, and that is because we have a high rate of migration between South Africa and other countries in the neighboring countries. And so our public health issues in South Africa are intricately linked to the public health issues of the neighboring countries and vice versa. Thank you very much.
Thank you so much, Mzi, for that wonderful talk. You've hit on so many points that are really relevant to our audience here today. I know there's probably a lot of questions that people have out there. I think it's really interesting to hear you talk about how, despite the availability of effective interventions, widespread public availability of a free ART, there's still issues with adherence and with lack of testing, et cetera. So really recognizing the role of mental health in some of these challenges of implementation is really fascinating to hear about. I'll open it up for questions to the audience. You can either put your question in the chat or feel free to please turn on your cameras and put up your hand, and we'll get started. Ian, over to you.
Hi, Mzi, that was great. I'm curious, one thing we've seen in Canada, and I think in a lot of Western countries, is a real reduction in stigma related to mental health. Excuse me, in the past 20 years, and it just seems every year that it becomes more and more normalized. And I'm just curious whether you're seeing similar trends in Southern Africa, and whether that might help with this, and just helping reduce the contribution of the burden of mental illness on HIV.
Mzi, are you still there? Oh, you're just on mute.
One question at a time, or do you want us to take a few?
Oh, one question at a time is fine, I think would be great.
Oh, sure. All right, thank you very much, Professor Coleman. So in South Africa, we have not seen a reduction in stigma against mental health, sadly. Yes, there is reduction in stigma against HIV, and that is linked to the wide availability of treatment for HIV, and thus making it less stigmatizing to be living with HIV and to be on treatment. And I think that would achieve that in South Africa and the Sub-Saharan Africa Africa in terms of mental health if we also did the same, if we addressed treatment for mental health, because a lot of our mental health problems go unnoticed because there are no facilities to test for mental health. There's a serious shortage of psychiatrists and psychologists, mostly concentrated. The few that we have are mostly concentrated in the urban cities, in the big provinces, such as Gauteng in Joburg, Durban in KZN, Cape Town in the Western Cape, and in most of the rural psychiatrist or psychologist. You will find that there are hospitals in 3 or 4 districts, for example, that share a mental health specialist who moves between these hospitals. And so if we were to increase research and increase information and demystify, because sometimes there are quite a lot of myths around mental health, and if we were to address the myths around mental health, then would impact on the reduction of stigma. And also if we were to provide treatment for mental health, because right now we do not have that in primary healthcare settings. Primary healthcare settings are the most accessible forms of healthcare in South Africa for the bulk of the population that does not have medical insurance. So because a lot of people in South Africa generally don't have medical insurance, they use the free services in primary healthcare services, and those primary healthcare services do not have treatment for mental health. I could ask JD, because I saw that JD is on the call, if he's got something to add later, because he is also a mental health specialist, and he is my colleague lecturing mental health in the Department of Nursing here at the Faculty of Health Sciences at Forte. So if JD has something to add, please feel free, JD.
Thank you, Prof. Mzee. There we go. Right, good evening to everybody here from South Africa. I'm also from East London, and as Prof said, I am a colleague here at the University of Forte. Yes, just to add with this presentation in mind, a few years ago, and when I say a few years ago, it was in the very early 2000s, the South African government decided, the National Department of Health, to also include the mental health care speciality into the mainstream of the primary healthcare services in South Africa. And unfortunately, what that caused was that patients with HIV and related, obviously, mental health issues now became part of the mainstream of patients. And in South Africa, because we have such a shortage of healthcare workers and healthcare facilities, these patients now they went undiagnosed, untreated, and most of them, if they were on treatment, they started defaulting because of the long queues, the long waits at the clinics, and obviously sometimes too sick to actually come to the clinic. And there were absolutely no follow-up because of the lack of services. So I hear exactly what Prof is saying when she says that we're not reaching that 95 target. And it's logic when you look at the amounts of numbers of patients that actually needs care and going undiagnosed, untreated, unreferred, and these patients just default, they relapse. And yeah, so in South Africa, and I'm sure that in sub-Saharan Africa, we have more or less the same problem. So there's also an issue of political will. We need to also change the mindset of our lawmakers, of our policymakers, to make them see that link between mental health and HIV. And I think if we can succeed in that one, I think we will be well on our way to meeting that 95 target. So thank you. It's a brilliant presentation, Prof. I enjoyed it. Thank you very much.
You've just answered exactly what I was going to ask as a follow-up, just an awareness like how aware people are in government of this link between mental health and HIV and related, say, risky behaviors that contribute towards the HIV epidemic. Do you think, maybe a quick question, do you think that like just in the general public, people are aware of any link between HIV or risky sexual behaviors and mental health?
I don't think the general population is aware of this relationship. I think to some extent, there has not been smart ways for researchers to explain the relationship to the general population. And that might make this issue slip. And when I say the general population, I also mean the health worker population. So the health workers themselves are not quite informed and educated about the relationship between mental health and HIV. And so, health managers and leaders. And that is why there is this de-link between the services, because in the primary health care, you will still find all the sexual reproductive health services, including HIV, but you will not find mental health services. Those are, in secondary and tertiary hospitals in South Africa. So we do need to do a lot in terms of the general population outside of the clinics in raising awareness about the relationship between mental health and HIV. But it starts with education around mental health in the first place, because that is where it's lacking. The only big organization in South Africa that is doing work around mental health is the South African Depression and Anxiety Group. And they cannot reach a lot of places. They work on volunteers. They do have a few paid staff, but generally in all the 9 provinces in the country, they've got volunteers and they don't have offices. And apart from the South African Depression and Anxiety Group, which is SADC, there's small NGOs as well that do work, but mental health tends to be part of the bigger projects, like part of work around children, part of work around HIV or violence. So there isn't a standalone focus on mental health, even though there is a recognition from specialists and researchers that we do need to address mental health. So because mental health is an invisible disability, a lot of people do not quite believe in it.
Great, thank you.
Thank you.
Thanks. The question from Ume.
Okay, hi, Prof. It was very nice to hear a presentation on HIV in South Africa. You know that I worked as a clinical psychologist in Botswana, so I had a lot of exposure to the HIV clients. I mean, HIV positive and newly diagnosed and other clients. So from my job experience there, I found, I worked at a tertiary hospital as a clinical psychologist, and what I found that the ethics of confidentiality about the disclosure of HIV status, and also the ethics of patients' consent to get their blood tested for HIV, I felt that that ethics is a barrier, because then the healthcare professionals also, like who would do the surgery with the patient, would also don't know about the patient's status and how they can be infected because of that lack of knowledge. And also I dealt with many clients who were infected from a HIV positive family member, not knowing their status. Like, for example, there was a girl her mother was HIV positive, and she used to take care of her and wash her blood-stained clothes and, like soiled clothes and other things. So she was not informed by the healthcare professional about the mother's status. And if she was informed, maybe she could take care of her with some safety measures. So so I'm just pointing out to these health ethics, that healthcare ethics, that and confidentiality, that it is a barrier, and also it is creates vulnerability to be infected. Thank you.
Thank you very much, Ume, for that question. One of the things that have happened, colleagues, over the past 10 years in South Africa and in the region, including Botswana, where Ume worked, is that we moved from what we called voluntary counseling and testing, VCT, to what we now call HIV counseling and testing, which is HCT. So that move has actually addressed one of the concerns that that Ume has. Whilst we still prioritize consent, and we're going to continue to prioritize consent, we are able to test more people now because testing has become routine. So we're doing routine counseling and testing instead of what we used to do in the past, which was voluntary counseling and testing. So the difference is that in the past, we used to educate about HIV and people had to voluntarily and willingly leave their homes to come and get tested at the clinic. Now, everyone who comes to the clinic in South Africa and in the region, you don't leave the clinic without an HIV test unless you opt out. So there's still the consent element, but at least now we are able to test more people. But still, that is concentrated in the clinics. And that is why we are not meeting our 95% of people living with HIV knowing their status. It's because all those who have not been sick for one reason or the other, have not presented themselves to the clinic, have not had the opportunity to be tested. And guess who those people are? Mostly men, because men underutilize healthcare services in this context, and mostly young people, because young people are generally a healthier population, and so they do not need to present themselves to the clinic. So young women start to present themselves to the clinic when they start to use contraceptives and when they start to give birth. So that those circumstances kind of force them to come to the clinics. But generally, we are missing out on a lot of young people who have HIV but do not know their status, even with the HCT, with the HIV counseling and testing. So we will not, avoid, that. The ethics of confidentiality, again, we're still going to uphold the ethics of confidentiality because they are very important for us as healthcare workers. I understand the concerns around exposure from from unsuspecting people or unsuspected people living with HIV, but confidentiality is one of the things and the principles that are very important for healthcare workers, and so we're still going to maintain that. Having said that, within the healthcare setting itself, with HIV counseling and testing, HCT, the linkages to care have improved because we are now able to refer people for care once they've tested on spot, on site. So yes, they still reserve the right to disclose their status as and when they want to disclose to the person that they want to disclose to. But within the healthcare management system, there are opportunities for people to be managed, even if they don't disclose to their families. So through that system, the linkages to care, we are able to offer people access to antiretrovirals, and we don't wait for CD4 count anymore. It's a test and treat. You test, you treat immediately. So it has worked so far. Thank you.
Thanks, Mzi. We have a question from Alison. Go ahead, Alison.
Hi, thank you very much. It's really interesting, and I've had about 3 questions throughout the discussion. The first one Ian took on stigma, and then I'm really been very interested in the conversation around primary healthcare, really, and the system itself and handling, the connections between mental health and HIV. And I guess I'd love to hear a little bit more on that, because of course we're hoping to move towards more integration and stronger primary healthcare centers, and that's or primary healthcare. And I guess I was a little discouraged by what Dr. Wagner said around, with the mainstreaming, that you saw care going down, and that actually people were being missed more because of the constraints to the system. So I wonder if you could just speak a little bit more about, perhaps within the health system in South Africa, is mental health and HIV at those upper levels, how siloed are they? And also, because I think sometimes that permeates down through the system and makes it harder for us to provide care in a holistic way. And I just wonder if you could speak a little bit to that, and what you see as perhaps a recommendation or thoughts moving forward on how we can think more holistically at the point of care, to make sure that we're also including mental health right at the point, perhaps when someone is getting their diagnosis or being put onto ARVs. So thanks, really interesting.
Thank you very much, Alison. There is a serious challenge with the provision of services. So at first, we had segregated services in South Africa. So we even had a situation where we had, certain days for certain services. So Monday it would be family planning, Tuesday child health, Wednesday is chronics and all. And so we segregated the services. But then we realized that that does not quite work. And of course, it wouldn't work because, there are certain days when you're just not available to do your services, and so you need to go on a Thursday for contraceptives, and if it was Tuesday, you've got to wait for the other Tuesday. So we introduced what we call the supermarket approach. So the supermarket approach was going to be the primary healthcare model. You go to the supermarket, you get everything you want, which means you go to your clinic, you get everything you want any day, anytime. And that's what JD was referring to. That so the current approach, which is the supermarket approach in our primary healthcare settings, every day all the services are there. But what does that mean? It means that you could wait for your service for 5 hours, when previously, when we had segregated, you knew that this was your family planning clinic, you go straight to your family planning clinic, and it was faster. But now you are, even when you get to the clinic, we have not segregated the queue. So we need to resolve queue management at the clinics, because you all stand in the queue and you all sit and wait in the queue. And you're just there to replenish your treatment. You're not there for bloods on this day. You're not there for counseling. You're not sick. You're just here to pick 2 bottles of antiretrovirals and go home. But you spend 5 hours just to be in contact with the healthcare worker for less than 15 minutes once you are inside the consulting room. So that is the system that's disappointing and disheartening to many people. And that is how we lose people. We are a very mobile community in South Africa, and the mobility is between the rural and the urban. So again, our smart healthcare system has not yet found ways for digitization. And it makes it difficult for patients to collect treatment anywhere they want to be. And so if you have moved, you had luck. It's very difficult for you to calculate because we have not digitized our systems as the Department of Health. So we are unable to provide that efficient service to people. In terms of research in South Africa, the period when a lot of people are at risk of defaulting is actually the period we are in now, December, festive season. Because the festive season is the period in South Africa where a lot of people who work in the big cities, they retreat and go back home to the villages. And that's the norm in South Africa. They go back home, and if they did not get enough supply, then they will have to wait until they go back to work in January to be able to get their treatment again, because the clinics in the villages where they go home for during holidays do not have their patients' records, and so do not supply them. And it makes sense from the clinic's point of view that if we don't have your file, we don't know, you can't just come with a with a clinic card. So our clinic cards are still handwritten, like those old school reports when learners used to cheat, and if you got 7%, you just put 0 and you got 70. So our clinic cards are still like that. You could write on it. And so healthcare workers don't trust patients. And that is why it makes it difficult. You've got to go back to your own clinic where the records will be. In terms of what is happening higher there, there's still the split. So in South Africa, you will still have the Directorate for Maternal Health, the Directorate for HIV, the Directorate for Mental Health. So it starts at the national level and it is replicated at the provincial level and even at the district level where the managers are, that there's a manager for different things. So if you walk into a typical clinic, I wish I had a picture of what a typical clinic notice board would look like. A typical clinic notice board in South Africa would have all these notices that different directors have issued for the clinic. So there's competition. The director for maternal health has, their own interest, and they've got all these notices that we are a maternal health friendly clinic. Then the director for youth services with all the things that says, if you're wearing a school uniform, please jump the queue because we are a youth friendly clinic. And then there's, the director for something else, and then there's VPs. So there is no coordination, there is no comprehensive service. The services, because of those silos that we see in the national level, provincial and district level, then they translate to that. We do, in terms of the healthcare workers themselves, we do use an approach that we call, we're training our health workers in South Africa to be able to treat most of the problems that most of the patients come with most of the time. So that means that a lot of our healthcare providers at the clinic should be able to deal with most of the things. However, there is also still an interest in professional specialization. And so when, we've got healthcare workers, mostly nurses with professional specialization, they too need to get an experience in the area that they've specialized in. And so if someone has specialized in mental health, they may not want to provide a supermarket approach because they need to gain the hours of experience in specialization in their area. So even though the areas of specialization should move to secondary centers and tertiary, which is hospitals. So people with specialization should be found more in those, but there are not enough spaces for them in hospitals. And so they still remain in the clinics. And that actually sometimes affects the service. What was the other question, Alison? Is that all?
I think that was it. That was extremely comprehensive and really helpful you paint a really vivid picture and to understand kind of the situation. So no, thank you very much. That was great.
Thank you.
Thank you so much, Mzi. I think we'll try to wrap up at 5 minutes before the hour to let everyone move on to their next meetings, or for yourselves late at night and to get on with your evening. We just really want to thank you for your presentation, for providing your insights and perspective on the situation on HIV and mental health in sub-Saharan Africa and in South Africa in particular. It's been really enlightening, and I think this has been a great topic for our webinar series this month. Just before we finish up, we want to launch an evaluation through a Zoom poll. So if you could just take a few moments to answer some questions about the session, that would be very much appreciated. And then thank you once again, Mzi. It was great to have you.